Okay, hello everybody. In the interest of time, I might get going. My name's Marshall Dalton. I'm the chair for this session. Unfortunately, it seems that our first speaker hasn't been able to come to the conference today. They may be unwell. And our second speaker hasn't actually uploaded their slides, and I'm not sure whether they're here at all. So my sincere apologies for those who want to see those first two talks. But we're going to have to begin with our third scheduled speaker. So I'm sorry as well to Seda, who was not expecting to speak so soon. But I'll introduce Seda Sacu from the Central Institute of Mental Health, Mannheim, and I'll let her describe her talk. Thank you.
Good evening. Many thanks for the opportunity to share our research today. I will be discussing how young-onset Alzheimer's disease impact the brain network hierarchy. I have no disclosures. Young-onset Alzheimer's disease is a rare form of Alzheimer's disease that manifests before the age of 65. It often presents with more aggressive clinical course and like faster cognitive decline and greater tau burden. Extensive research has established that Alzheimer's disease disrupts the communication between functional brain systems. However, only few studies conducted in young-onset Alzheimer's disease investigating the connectivity of large-scale brain networks. And most of these studies focused on default mode network, reporting both increased and decreased functional connectivity in the DMN. In our previous work, we investigated resting state effective connectivity within the DMN using spectral dynamic causal modeling. We found that patients with young-onset Alzheimer's disease uniquely exhibit increased input sensitivity in the frontal regions and also increased excitatory connectivity from medial prefrontal cortex to posterior DMN nodes. We argued that this increased excitatory communication could be related to amyloid beta-induced neurotoxicity, which can further explain the disease propagation and cognitive decline. However, the network alterations seen in young-onset Alzheimer's disease are not limited to default mode network. It can be also identified in other large-scale brain networks, such as salience network and dorsal attention network. And also, importantly, DMN interacts with the other networks, which might be partly responsible for the changes we see in default mode network. Also, the brain has a hierarchical organization. DMN shows reproducible anticorrelations with task-positive networks, such as salience network and dorsal attention network. And this anticorrelated nature found to be related to higher cognitive performance. However, it's unclear how DMN interacts with the task-positive networks in Alzheimer's disease. In the current study, we aim to investigate hierarchical relationships among the DMN, salience network, and dorsal attention network in patients with young-onset Alzheimer's disease and healthy controls. We expected to find excitatory within network connectivity and inhibitory influences from task-positive networks to DMN in healthy state. We also hypothesized that this hierarchical organization would be impaired in young-onset Alzheimer's disease. We specifically expected to find reduced inhibitory influences from task-positive networks to DMN, which can also explain why we found hyperconnectivity in DMN previously. By providing special mask from a previous study, we identified the networks of interest using constraint independent component analysis. Then we extracted regional time series from 11 regions across 3 networks. We estimated resting state effective connectivity using spectral dynamic causal modeling, which also enabled us to identify direction and the valence of connection, such as inhibitory or excitatory connections. We then performed the parametric empirical bias to characterize the group differences in effective connectivity, and all analyses were controlled for age, sex, and head motion. To reveal hierarchical relationships, we first estimated mean connectivity strength between networks. Then we calculate the hierarchy score by subtracting the connectivity strength of incoming connections from the connectivity strength of the outgoing connections. That means if a network has stronger outgoing connections than the incoming connections, it will have a higher position in the hierarchy. Here are the results. We present here the full effective connectivity matrices for healthy and patient groups. Pink colors represents the excitatory connections, while the green color represent the inhibitory connections. These diagonal blocks shows the within network connectivity. As you can see, they are predominantly excitatory connections, confirming that these regions work together in synchrony. However, in contrast, we found inhibitory influences from task-positive networks to DMN. Also shows that the activity of DMN is regulated by task-positive networks. Here we see summary metrics for between network connectivity. As I mentioned earlier, we can still see this inhibitory influences from task-positive networks to DMN in both groups, as well as the inhibitory influences from salience network to dorsal attention network. We also estimated hierarchy score for each network. We found that in healthy controls, salience network was at the top of the hierarchy, followed by dorsal attention network and DMN. When we directly compare the patients with the controls, we found that patients had reduced inhibitory influences from task-positive networks to DMN. But also interestingly, we found that DMN connectivity, like DMN was sending the inhibitory influences to dorsal attention network only in patients. To conclude, we identify a hierarchical organization in healthy state characterized by excitatory connections within the network and also inhibitory influences from task-positive networks to DMN. Previous effective connectivity studies also found a similar hierarchical organization in adolescents and adults. Patients exhibited reduced inhibitory influences from task-positive networks to DMN and also inhibitory influences from DMN to dorsal attention network. These inhibitory influences might provide a control over a brain system, particularly when attention must be allocated to external tasks. Therefore, maintaining the balance between task-positive and negative networks is crucial for cognitive functioning. And reduce inhibitory influences from task-positive networks to DMN, as well as the inhibitory influences to dorsal attention network, might contribute to cognitive decline in Alzheimer's disease. And in future, we would like to replicate these findings using an external data set, and also we would like to associate these connectivity changes with cognitive performance. And lastly, I would like to thank Dr. Jonathan Schatz and Dr. Adil Razi for their support and supervision, and thank you all for your attention.
Okay, hi. Thank you. Do we have some questions for the audience? And I'd like to really encourage students and early postdocs particularly. We want to make it a relaxed environment, so be brave and Do we have any questions?
Oh, hello, I'm Italo. Early onset Alzheimer's disease usually affects the prefrontal cortex earlier than late onset Alzheimer's disease. Do you think these findings could be related to that? And have you tested if it relates to cognitive measurements of executive function?
Thank you very much. It's a very nice question. Actually, we didn't have data for clinical staging, which was a big limitation. We couldn't check, if it's like, the early disease feature. But we also checked the cognitive functioning, especially like a higher sensitivity of prefrontal cortex. Input sensitivity was related to lower cognitive functioning. So we were seeing that some of the connectivity metrics were related to cognitive functioning in the previous study. For this one, we haven't checked yet.
Okay, thank you.
Thank you.
Okay, are there any other questions from the audience? Would you mind coming over to the microphone over here?
Thanks for a great talk. I was just wondering, when you say that there were, contributions to cognitive decline, did you look at specific neuropsychiatric measures? Like you're looking at DAN, salience, and DMN, which are involved in different executive functions and attention. So I just wondered if you could be more specific.
Yes, I would like to be more specific, but we haven't checked that part yet. But we have cognitive measures. We have mini-mental tests and also several cognitive tests in other fields like memory and visual skills. But we haven't checked it yet. But in the literature, there are studies showing that when this anti-correlated nature reduced, it's related to cognitive decline. But we also want to check this in our data set.
Thank you.
Thank you.
Yes, another question?
Hi, thank you for the talk. Very nice. I understand that you have presented the neuronal parameters from the DCM.
Yes.
Have you looked into the hemodynamic parameters as well, and were there any changes between the groups?
No, not really. We only check the connectivity parameters and we use the default settings.
Okay, thank you.
Yeah, thank you.
We also have an online question through the app, and please remember that you can submit questions in the OHBM app. I'll just read this one out, and well, we don't have to worry too much about interest of time if we've lost our first two speakers, but the question is, will different molecular alterations, for example, presenilin APP, trigger different level or functional regional change? I hope I read that.
Potentially,
yep.
yes.
Mm-hmm.
And also, we would like to really integrate proteinopathy data, like amyloid beta or tau data, but we didn't have this data. And for the genetic part, we have APOE4, but I haven't still checked if it's really related to these factors yet. Yeah.
All right, great. Okay, if there are no more questions, please join me in thanking.
Thank you.